It's a great honor to talk in this prestigious meeting today. Endoscopy intervention of gastric cancer include not only bleeding control, but also many other areas. The topics of my presentation will include various issues about endoscopic treatment of gastric cancer. I'd like to start with the history of gastric endoscopy resection in Korea. This is the first small clinical report on endoscopic treatment of early gastric cancer in Korea in 1996. Professor Hyun Chae-jung performed all the procedures, and I was the first author of that report. I was a senior resident at the time. This is one of my early experience of gastric ESD in 2005. I used paper medical record and Polaroid films at that time. And this is the national statistics. For about 3 years, 23,000 endoscopic submucosal dissections for early gastric cancer was done. In the year 2014, it was more than 7,000. The mean age of patient was 65 and male was 74%. Mean duration of hospital stay was 5 days and mean medical cost in 2014 was $1,300 US. Surgery was done in 7% within 3 months. This is the volume of surgery and ESD at my institution at Samsung Medical Center. More than 35% of gastric cancers are initially treated by ESD in the year 2018. Next topic is indication. There are two types of indications. Absolute indication means differentiate type mucosal cancer without ulcer, not bigger than 2 centimeters. Expanded indication include differentiate type EGC, bigger than 2 centimeters, and selected cases of undifferentiated type gastric cancers. This is a real world statistics. Among 355 early gastric cancers initially treated by ESD, 120 cases, this is 34%, belong to the beyond absolute indication group. Some of them required surgery. 10% of patients in the absolute indication group were initially treated by surgery, and you can see the reason in the box at the right-hand side corner. Suspicious lymphadenopathy is the most common reason for surgery. In Korea, ESD candidates are usually selected by absolute indications. After ESD, expanded criteria is applied to determine whether the resection was curative. And there are controversies about the safety of ESD for expanded indication cases, especially because Korean studies consistently showed higher risk of lymph node metastasis in expanded indication cases than Japanese data. And I will show you some of them. A Korean practice guideline for gastric cancer was just released. The first statement is about absolute indication. An endoscopic resection is recommended for well or moderate differentiated early gastric cancers meeting the following endoscopic findings. Size less than 2 centimeters, endoscopically mucosal cancer, and no ulcer in the tumor. This is this is a small cancer. And total gastrectomy was done for a 45-year-old lady with just 1 centimeter signal ring cell carcinoma. In my opinion, it is too much. 1 centimeter tumor and total gastrectomy. What would you recommend for a lady, 40 years old with a small flat signal ring cell carcinoma, less than 1 centimeter. And I performed the ESD, and the final pathology was signal ring cell carcinoma, 10 millimeter, limited in the lamina mucosa, clear resection margin, no lymphatic invasion. That means absolute no chance of recurrence in the near future. So ESD for expanded indication can be selectively performed in the individual cases. Flat, small signal ring cell carcinoma are frequently treated by ESD in Korea recently. And statement number 2 is about expanded indications. They say ESD should be performed, and the recommendation level was week 4. So this recommendation is mostly proposed by surgeons, and surgeons are more aggressive than endoscopists in Korea. Next topic is outcome. Outcome of endoscopic treatment of EGC with the different type histology is well established. We have ITT data and also PP analysis such as long-term follow-up data after curative or non-curative resection. At my institution, we performed the propensity score matching analysis between the two groups, endoscopic resection and surgery, for differentiated type early gastric cancers. The overall survival was almost the same in the two groups. But because of the metachronous recurrences, disease-free survival and recurrence-free survival is better in the surgery group. However, there was no difference in the disease-specific survival. It's a single-arm, long-term follow-up data for curatively resected differentiated type early gastric cancers. Excluding metachronous recurrences, we experienced only 1 case of local recurrence and 2 cases of extragastric recurrences. And this is the overall survival. There was no statistical difference between absolute indication and expanded indications. And these are the pictures of 2 extragastric recurrences in our series. The top case belonged to the absolute indication group, and the lower case belonged to the expanded indication group. This is non-curatively resected differentiated type early gastric cancers. In cases with lymph node metastasis, 70% were operated and 30% were observed without surgery due to many reasons. In the surgery group, 11 patients have lymph node metastasis, which means about 6%. In terms of overall survival, additional surgery after non-curative endoscopy resection, additional surgery was related with better outcome, 10% additional survival gain in 5 years. And survival benefit of additional surgery after non-curative resection was shown in a propensity matched study by Dr. at Korea National Cancer Center. As you can see at the right side picture, the overall mortality of observation group was higher than that of matched standard surgery patient. But maybe we are doing too much surgery after ESD. Do you think surgery is necessary for mucosal cancer with lymphovascular invasion only? As you can see in the red box, in lymphovascular invasion positive patient within traditional absolute indication, there was no lymph node metastasis in surgery. So careful observation without additional surgery can be an option for this small group of patients. And the final topic of my presentation is education. There are 4 must-knows before starting EGD, and hands-on training, side-by-side hands-on training is very important to learn ESD techniques. Different types of endoscopic knives are available in the market. Recently, hybrid knives mixing two different functions in a single catheter is getting popular. This case shows how I use the H-type ESD knife mixing two types of function. It is made by a Korean company named Finemedix. At first, I start with I-type tip for marking and circumferential cutting, and then I can change into O-type knife for a rapid submucosal dissection. It can make the procedure quite fast. ONESTEP ESD knife has dual life function and injector function in a single catheter. We can change from knife and injector very easily. And management of complication is a great part of ESD education. Most perforations can be treated easily with endoscopic clipping without surgery. When the resection is big and close to the cardia or pylorus, short-term oral steroid can be used for the prevention of obstruction. The hospital stay for gastric ESD is usually 4 days in Korea. For the beginners, hands-on training using a pig stomach model is very useful. Before starting ESD for the first time, beginners should have some experience as the first assistant. With some cases, the main operator usually gives the beginners to do part of the ESD steps. And the ESD, this is the ESD of the first procedure of my young fellow doctor. And Tele-mentoring using iPhone Facetime app is a very useful tool for ESD beginners. And international mentoring is also possible. If you want some real-time comment from me, send me an email and I can help you from Korea. Yeah. Finally, I'd like to show you an unforgettable case for me, personal case. I performed an ESD procedure in a surgical ICU. This patient was on cardiopulmonary support, ECMO, due to dilated cardiomyopathy and was waiting for cardiac transplantation. And during the pre-cardiac transplantation workup, an early gastric cancer was found. So I performed an ESD at a surgical ICU. And the procedure was done as usual. The problem was delayed bleeding because the patient cannot stop warfarin. Anyway, after a successful cardiac transplantation 2.5 years ago, the patient is living happily at his home. Ladies and gentlemen, I'd like to conclude my presentation by saying that ESD is widely performed for early gastric cancers in the absolute indication in Korea. Annually, it is more than 3,000 cases. 1 out of 3 gastric cancers are treated endoscopically in Korea these days. We are still very careful about expanded indication cases. It's done usually for flat signal ring cell carcinomas less than 1 centimeter. And starting the role of the first assistant is the beginning of learning ESD techniques. Thank you for your attention.